And it's my great pleasure to introduce Professor Fabian Kiessling. He's the director of the Department of Experimental Molecular Imaging at Aachen University and also director of the Helmholtz Institute of Biomedical Engineering there. And he will talk about the future of clinical cancer diagnosis and how it is going to play a role in the future of precision therapy. Fabian,
Thank you very much, Twan, for the kind introduction. Actually, last year I was quite depressed. I was doing molecular imaging research for more than 10 years, and I realized that really only very few new diagnostic compounds have been successfully translated into clinics. And my impression was that even the cleft between the preclinical research communities and the clinical reality become rather bigger than smaller over time. And this brought me to a point where I thought for the next 20 years of my research, how do I want to focus the research of my institute? What should we do to do something meaningful, something that really helps in clinical reality? And in this context, I thought, what will be the next big challenges and changes in the world of clinical diagnostics? And this inspired me to write a short editorial piece for European Radiology entitled The Changing Face of Cancer Diagnosis from Computational Image Analysis to Systems Biology, where I made 3 major points. The first is that I'm very sure that in the next years liquid biomarkers will replace indications for many imaging applications in cancer screening and monitoring. I'm also very sure that computer-assisted diagnosis will take over major parts of routine image analysis. That means that there will be new areas of activity for radiologists and nuclear medicine people. And I think that what we need is a clustered and combined analysis of different diagnostic information coming from radiology, nuclear medicine, omics, and also histopathology. Just to give you an example, and you may know these publications about the Cancer-Seq trial, just by taking a drop of blood with this assay, it's already possible to detect 5 major cancer types for which no screening tests are currently available, meaning the ovary, the liver, the stomach, the pancreas cancer, and the esophagus cancer, with sensitivities between 69 to 98% and specificities of over 99%. And this liquid biopsy assay could even localize the cancers and assign them to the right organs correctly in 83% of the patients. So the question is, what will then be the future role of imaging? And I think that imaging may be less needed for screening populations or for making the early first diagnosis, but it may move closer to therapy, where the question is, how can we localize and stage the tumors to select the right therapy? How can we do pre-selection of patients to certain therapeutics or interventions? And I think that in future imaging will play an increasing role in supporting and enabling interventions, as you will see in the next minutes. In order to do so, I think we also have to make the diagnostic data, and particularly the imaging data, much more quantitative as it is now, and for that purpose we really have to focus and take efforts in medical image analysis. And I give you here an example for example, assessing arterial stenosis. Usually the radiologist just looks at a slice image and then draws a diameter, but if it's not orthogonally cut, he may not correctly assess the stenotic area. You can do that with computational power for a whole patient if you just segment the organs and the vessels in 3D. And what we did here is that we simulated an elastic sphere that moves through the vessels. And then you see that if you have a bifurcation, the diameter goes down and stays at a certain level. Then with the next bifurcation, it goes further down. But if you have a stenosis, you have a dip in the diameters of this elastic sphere, indicating that there's a stenosis. And so the system can automatically tell the radiologist, look, here's an area where you have to take a closer look. There might be a significant stenosis. Same situation for cancer delineation and segmentation, what you see here is a typical ultrasound image, and you see that there are some problems assigned with it. You have some bright areas in the center, and here you see that the margins are not completely connected. And if you now take a computation system, use artificial intelligence for that, such an algorithm can easily detect that the center part is not contributing to the border, so it is removed, and then it analyzes the borders around it, and it finds some symmetry here, and based on that it can start to reconstruct the areas that are not completed, leading to a tumor segmentation. Just let's wait a second here, that then can be used to extract quantitative data. And if you compare that approach, for example, to manual delineations from observers, you see that's quite good already. It still needs to be improved, but it's quite good, but providing for sure a much lower user dependency and providing a higher reproducibility. If you then have the correct borders, you can determine quantitative measures out of these data. And usually in radiology, we have very nice images with much contrast and very much anatomical detail, but we still do not use the full information that is in the images for diagnosis. We still look for the borders, whether they are spiked or whether they are round, for intensities. But there's much more information that can easily be extracted by computer systems. And for example, coming back to this ultrasound example, you can just take the B-mode images here, do some first order statistics on it, then you can inject contrast agents, analyze the vascular structures such as numbers of vessels, you can quantify relative blood volume, you can add textural features like the distances between vessels and the statistics that are assigned to it, and you can also include the functional data about perfusion and velocities, and then you get numerous data that you can use to make the right diagnosis. And we did that in 3 experimental tumor models with different angiogenic profiles: the ovarian MLS cancer, the squamous cell carcinoma A431, and the lung cancer cell line A549. And just by using 3 independent parameters, we could correctly assign, using a simple Euclidean distance approach, all the tumors correctly to their histological group. This even improves if you combine the image data with other data, such clinical data and data, for example, about gene expression. This was done by colleagues from Maastricht University, Iris Lambert, and colleagues who used CT data and combined them with the other one. And they could clearly show, firstly, that the data are complementary, and that if they are combined, they allow a quite accurate prediction of the survival probability of the patients. Well, what does that mean for the nano field? And I may show here one very famous example from Harrington about EPR. May it exist or not, let's call it EPR now. Yeah? And we all know that EPR is heterogeneous not only among different tumors, but also between tumors of the same entity. And this was shown by Harrington using a theranostic approach where liposomes were radiolabeled, and certainly he got very accurate results with that. But the question is, for the clinical reality, do we really need that kind of sophisticated theranostics for that approach? Or maybe we can already use a companion diagnostic, like this was done by this Boston group, who repurposed an iron replacement agent called ferraheme. It's an iron nanoparticle that also gives MRI properties, and they could very nicely show that the accumulation of this agent very nicely correlated with the response of patients to the nanotherapy. Maybe we can even make it more simple and use diagnostic methods that are already implemented in the clinics, and we did that quite some years ago, where we just correlated the relative blood volume that can be obtained by contrast-enhanced ultrasound with the accumulation of HPMA polymers. And you see that there's also a quite linear correlation with it. Maybe imaging is not necessary at all. Maybe we can derive the whole information already from histology, from the biopsy. But interestingly, as you see here, vascularization did not correlate very well with drug accumulation. This is due to the fact that in tumors, a significant portion of the vessels do not carry blood usually, but they are still counted as vessels in the histology, yeah, because they are compressed to the high interstitial pressure. But what we found is that histologically there's a very high correlation between drug accumulation and macrophage density, which underlines the finding of Weisleder, who claims that the macrophages are an important reservoir for nanodrugs from which they are released. So now the question is, which biomarker should we really use to predict nanomedicine accumulation? Is it an imaging biomarker? Is it a histological biomarker? And I don't have a clear answer yet, but it makes clear that the information might really be complementary. Maybe the ideal way to predict nanomedicine accumulation is taking just a normal contrast ultrasound scan or CT scan in combination with the measurement of macrophage densities by histology. So far, I only talked about using imaging to predict drug response, but you can also use imaging to support drug accumulation. And this is an example from a clinical trial that is currently running in Aachen, where we use these ultrasound microbubbles to improve the perfusion and vascularization of tumors. As you see, if you insonate these microbubbles, they start to oscillate. And this oscillation process can open vascular junctions, but in peripheral tumors, much more important, it also opens compressed vessels. And if we perform contrast and ultrasound continuously during the infusion of chemotherapy, as you see here, over time, we significantly increase the vascularization of these tumors from an almost avascular to a quite well vascularized phenotype. And we assume that this will also, at least preclinical data suggest that this will also lead to a significantly higher accumulation of the chemotherapy and thus to better responses. So far, we only have 15 patients, so it's still too early to say something about a therapeutic outcome, but at least the modifications on the vascular system by these interventions, they are significant. So what do we really need to consider these new trends in diagnostic imaging? I think we have to consider new infrastructures. We may have to break down the very stiff borders between radiology, nuclear medicine, pathology, and omics analysis. We have to implement comprehensive diagnostic centers where we do data sampling in a very standardized way. We have to build up databases that allow to really merge these data and to analyze them together, histological data, radiological data, omics data. We need methods that automatically extract quantitative features from our image information to make it comparable with the omics data, and this then has to feed in digital disease models, so it generates an important link to systems biology, which then help us to implement precision medicine and to improve drug discovery. I think this was my last scientific slide, and I would like to summarize my talk. I think there are multiple diagnostic options to characterize tumors and to monitor therapy, but they are at the moment really not fully exploited concerning its expressiveness, meaning with how much information we can really get out of it. Yeah? There's insufficient integration of data from imaging, histology, and liquids into meaningful assays, and I think you can really use here the new computational power that is now available. I think the future in diagnostic lies in multiparametric diagnostics, computer-assisted data assessment, and integration. And this will be a very important basis to generate digital disease models. And for that purpose, we need that kind of new comprehensive diagnostic centers. And one of those has just in May be installed at RWTH Aachen University. With that, I would like to end my talk. I thank you for the attention. We'll be happy for the discussion.
Thank you very much. Questions or comments, please?
So your ultrasound bubbles, so in principle very interesting, of course. But how many lesions can you treat simultaneously? Because if you have to go one by one by one by one, you simply have a logistic problem because you cannot keep the chemo flowing, right? So what are the technical solutions there?
So far we can only treat one That's why we also focus on neoadjuvant chemotherapy of the breast, particularly of patients who do not have metastasis. Yeah? There are still many challenges and questions that need to be addressed first before one would implement it for more complex situations. For example, currently we are still moving the transducer by hand over the tumor back and forth, yeah, which is not very efficient. It would be much better to do that in a 3D approach with really a 3D matrix transducer. I know that in France there are some groups that also work on similar topics very efficiently. So I think there are many open questions that first need to be addressed here. For example, also it's not clear, should we let these bubbles really disintegrate? Should we destroy them, or should we just let them oscillate? Which bubbles are the best for that? How long should we do it here? How long remain these perfusion effects? It seems to be just only for 1 or 2 hours. That is our first impression. Yeah. So you need to really have a good timing. So many open questions still. But what you can say for sure is the effects on the vascular system, at least in breast cancer, they are really dramatic.
Okay, thank you. Mm-hmm.
So using omics-based liquid diagnostics as well as functional PETs, also other based diagnostics, we've been hoping to get more sensitive towards detecting earlier stages of tumors. But in fact, this is not the case. The imaging, the traditional imaging, seems to be still superior to all of these other agents. So what is your prediction of how this will evolve? Will it still be the mainstay for a 3 millimeter metastasis to be detected by MRI rather than any other agent?
It's a difficult question. I don't have an open, I don't have a clear answer to that because nobody really knows it. Nobody knows how good with respect to metastasis detection and small lesion detection these blood tests can be. Yeah? As I said, I think that in the next step, the blood analysis will become very important for screening examinations. Because in screening, the first question is there a lesion or not? And screening all patients with imaging is very expensive. So I think for this indication, imaging will be replaced to a certain extent by omics. Yeah? The next step would be to analyze how big is the tumor, does it have metastasis? And I think at that point, imaging will play a major role also in the next 10 or 20 years. And I think it's still an open question how good the blood test can be in this context. I don't know it. Maybe it's also a combination again from different diagnostic measures.
I have a related question. So to both of the first speakers, how important do you think imaging is? If we consider that PD-1, PD-L1 therapies will be out there for all types of cancers in the future, is imaging really that crucial, or do we just need to figure out that the patient has cancer and has this type of cancer?
It's a very interesting question. I also discussed that already with some industry partners. Yeah, it depends on the question. Maybe you also answer to that. It depends on the question, what is the crucial information? Information about the blood and the immune system as a whole, or the immunological changes that really occur inside the tumor? Yeah, because these may be more difficult to get from blood analysis. And if we know that, yeah, then we could make a prediction out of that. But I think at the moment, for me at least, it's too early to make a clear statement here.
What do you think?
Well, ideally, cell-free DNA would be one of those parameters that would change the landscape. Right now, it doesn't because of a sensitivity problem.
Mm-hmm. Exactly.
So even in patients who have very advanced lymph nodal disease, metastatic disease in melanoma, you pick out by cell-free DNA not more than 10-12% of that patient population. So you cannot base, at this point in time, any decision-making on adjuvant therapy, for instance, and things like that, on cell-free DNA. So it needs to be improved by logs of difference, not just, this is not the biology problem. So actually, if it's logs of difference, then it's a technology problem, and we will actually solve it, right? If it's a biology problem, we may not solve it. So I don't know. Obviously, in the end, we still would like to believe the dream that you can detect anything in a blood of drop, in a drop of blood. Well, we'll see.
As he says, it's a dilution question. So if you have it from the blood into from the tumor into the blood, it gets diluted, and then we get to these sensitivity problems.
So imaging then should only be a tool to direct therapies to deal with local problems, because that's where it's going to be very helpful, but not for micrometastatic disease. I mean, micrometastatic disease, micrometastatic disease. All you need to know is it there, yes or no?
Exactly.
Right.
Yeah.
Exactly.
So thank you very much, Professor Kiessling, for this interesting talk. We'll move on.